sliding onto belief two, I think. But the other critical point of that was a mistake was thinking everybody was susceptible. And that's a belief that sort of somehow still seems to hold. And that was the belief that leads to this sort of tsunami model where it keeps going and going and going until everybody's caught it. And that happened nowhere at any point. Yeah. And, you know, we've seen so many COVID waves. It's very predictable how long it takes before they peak naturally. We know that from evidence everywhere. And this is really, really important, because I suppose at a stretch, if you pretended this virus was something we knew nothing about, you could say we didn't know that until that had happened. But it's not something we knew nothing about. We knew it's a coronavirus, and we knew that they are very seasonal, and they do have these sometimes quite, you know, dramatic surges before they go away again. So we did know that, and we don't know as much about coronaviruses as we do about influenza. But influenza viruses are, you know, also respiratory viruses which are very seasonal. So we could have thought, well, what do we know about influenza? And what we knew about that is that they only about 5 to 15% are susceptible to any sort of influenza variant, as it were. And if you look at papers from before this period, where people were talking about what would happen if we had an influenza, you know, that was mutated and that was unfamiliar, and, you know, what would the outcome be? In fact, there was one that was written about influenza that had been a lab leak, a sort of gain of function influenza. What would happen? And the basis of that thesis was, well, maximum 15% are going to be susceptible. I think, well, that's a very sound reasoning. So why on earth were people talking about it being 85%? You know, this is an extraordinary difference, really extraordinary. And there is a problem we have that modelers, first of all, their entire career is about this sort of event. So they want to spin it out and exaggerate. You know, the worse they can make it, the better it is for them. They become the heroes, as it were. So they've got all the wrong motivations. And on top of that, if they say 85% are going to be susceptible and they've got it wrong, there doesn't seem to be any consequence for them. If they said, oh, don't worry about this, nobody's susceptible, that's when they have a consequence, because they've undercalled it. So they have this perverse incentive to always be massively overcalling it. And it's the politicians who take the flak for overreacting, but the politicians didn't seem to have the common sense, frankly, to question these people. And I think that's really sad. It's almost as if they were being bamboozled with computer models, when actually the question was very, very simple. Anybody could have an opinion on how many people are going to get it, how many people are going to die of it. It's two numbers. You don't need a computer model. That's a very simple back of the envelope sum. And so you can then, as a politician, interrogate those two questions, but nobody really did.
The modelling disasters in the pandemic, we could spend a long time talking about that. Assumptions based on essentially no information at all, fed to politicians with essentially no background science at all, who were not equipped to ask the sort of scientific questions that would have interrogated this data, or this apparent data, in an analytical format. So what we're saying here, just to clarify the science, Claire, is that in any one wave, let's take the Wuhan wave, the original virus, whatever we want to call that. What we're saying is only a small number of the population would actually be susceptible to becoming infected and getting sick with that virus. Is that what with that particular form of the virus? Is that what we're saying?
Yeah, absolutely. That's what we're saying. That if you look. There's something slightly odd about what happens that nobody really can explain. And I think that's been part of the problem, is nobody willing to talk about things we can't explain, you know, pretending there's no doubt in the situation. So one of the things we can't explain is peak deaths are always in January, right? Respiratory virus peak deaths always happen in January. Now, if viral spread was to do with how we're interacting with each other, that wouldn't be the case. It would come and go much more randomly, and it wouldn't be predictably always in January. Now, it isn't only always in January. You know, the other peaks are predictable as well. So if there is an autumn wave, which we have had every time, then you see the peak deaths at the end of October, beginning of November. If you have a spring one, you see peak deaths in early April. And if there's a summer one, peak deaths are in July. We haven't seen peak deaths that are falling outside of that pattern. So if you can see that pattern, then you'll say, well, why is it that it's always going to be falling in November, as we've just seen, before rising in December? Like every single year it has fallen in November before it rises in December. So that is tricky, because if you try and model it on anything to do with viral spread as we know it, that doesn't fall out. And so, but if you think about it as being human susceptibility, then you get that predictable pattern. So we've got something causing a wave of susceptibility at certain times of the year with predictable peaks, and we can't explain what it is. So something causes a fraction of the population to become susceptible, and whatever variant is around at the time is the one that will be going with that. And that's why the peaks are predictable. And the reason I say that, because that is quite a sort of mind-blowing way to think about it compared with what people normally think. But one of the points of evidence to support that is this. If you looked at people who are in hospital, you've got two types of people in hospital. You've got the ones who had COVID, got sick, and came through A&E. So they're the sort of proper COVID admissions from the community. And then you have people who are in hospital for other reasons who catch it in hospital. Now, the conventional story would mean that you had a peak of admissions from the community first, and then it spreads in the hospital, and you have your incubation period, and then you get peak, oh, we've got these patients in hospital catching it now. So your hospital cases would be after peak admissions. But what actually happens is that the cases in hospital peak at the same time as they peak in the community before the admissions. So the cases are already falling in hospital before you've got peak virus in the hospital. So that suggests there's a susceptibility thing going on in the community that's also affecting all the hospital patients. And of course, hospital patients are sick, so their immune systems are already struggling, and so their percentage of people in a hospital environment that are going to end up positive is going to be higher than in a community environment, but the timing of it is the same.
So interesting. So there's something about the time of the year, the ecosystem of the planet that we live in, us as human beings and all the multiple factors that influence our susceptibility to the virus, interacting with the innate biology of the virus in its ecosystem. That means that this is highly seasonal. Yes. And the cases tend to move as a wave, almost like pieces of wood drifting down a river or something. They're all moving, kind of moving together.
Yeah, and I mean that's true, and it's complicated. You know, that's the point. There's a lot of factors at play that we can't pretend to understand, and pretending to understand it has just made everyone look stupid. Mm-hmm. And one lovely analogy that I quite like is to say it's a bit like tomato blight, where everything's fine in your allotment, it's all going well, and then overnight they're all gone. They've all just, like, the conditions are such in the environment that suddenly this fungus that was around gets the opportunity to just take off, and all the tomatoes are gone. And I think if you understand it that way, you can also understand why some of these periods, like spring 2021 here, you don't see a wave. And obviously that was attributed at the time to vaccine success, but it was the same in Portugal and Ireland. I think it was a geographical phenomenon where the very westerly part of Europe didn't have a spring 2021 wave, and Eastern Europe had it badly, in the reverse of what was seen in 2020.
Yeah. So any one wave, only about 15% of people are susceptible. So the modelers got the inverse wrong. The modelers were saying it's 85%.
Yes.
Whereas actually 85% that probably weren't susceptible in any meaningful way.
Exactly the wrong way around. Yeah, most people are bystanders, really.
It's dazzling how wrong they got this. And yet absolutely. The whole policy was based on these particular papers from particular individuals who happened to breach the lockdown themselves from particular institutions. It's just incredible that so much weight was put on such tenuous, exiguous evidence. It's mind-blowing.
Worse, that it wasn't revised.
Yeah.
That's the worst crime. Okay, make a mistake. We all make mistakes, right? But at what point did they say, oh, look, now we've got some actual evidence of how it actually behaves in the real world. Let's revise this. And they failed to do that, which is just catastrophic. I think one of the things that people haven't talked about much at all, which is very, very telling, is this measure called the secondary attack rate. So the secondary attack rate is a measure of how many people in a household will catch COVID when somebody in the house has got it. And you can see in the literature, you see huge variation in the claims on this. And that's largely because a lot of people don't take the care to ensure that they're not including people who caught it at the same time as each other. So if we've got 6 people in our house. So when my husband and I were out and caught it, we brought it home, and then there was a period, and then 2 of my children were ill. So our secondary attack rate was, of the 4 children, 2 of them were ill. So it was 50%. But if you look at that over the whole population, Public Health England were very careful about how they measured it and wouldn't have included me and my husband in the sum. They got 10%. It was 10% for the Wuhan wave. It was 10% for the Alpha wave. Now, after Alpha, a large number of people vaccinated. And so at that point, you'd think, well, it should have reduced the number who are susceptible. It should be less than 10%. It was 10% for the Delta wave.
Exactly the same.
Pattern. And worse, like the thing that really hasn't been talked about is it was 10% for that first Omicron wave. And the thing is that this does not add up, because the other data on Omicron so the PCR positives say were huge numbers. And the public health data on the number of people that developed antibodies also suggested huge numbers of cases. But I don't understand how they came to those numbers if only 10% were susceptible. Like, there's something that doesn't add up. And they stopped publishing that figure subsequently. So from March 2022, we haven't had that figure.
So the confusion is that you and your daughter could have been out, both caught the virus, maybe at different places, but at the same time, compared to the fact that maybe you could have caught it and then passed it on to your daughter, and this nuance wasn't really taken into account in the calculations of the secondary attack rate.
It was more the point that, say, if my husband and I had gone out and both caught it at the same time, we're both index cases, and so we shouldn't be counted in each other's secondary attack rate. That was the math, yeah.
Got it. This 10 to 15% susceptibility, Claire, is this consistent with other diseases? How does this compare to influenza, for example? Do we know?
Yeah, so for influenza, it's 5 to 15%. For measles, it's it is something like over 85%. It'll be 90%. So that was the model they were using. They were using this model of measles and hypothetical scary virus that they do all their modelling on, because that's their career. As I was saying earlier, they pitch their work to funders on the basis that they can tell you about scary viruses. So their models are based on this hypothetical scary thing that doesn't probably exist, because otherwise, who cares, right? What are you going to do about it otherwise? So
the model becomes an irrelevance.
Yeah, they have to come up with stories that give them relevance, and the stories that give them relevance are, these things can spread to everybody, they can be lethal, and we can do something about them. You have to have all 3 for their careers to be relevant.
I mean, I'm not a virologist, but I certainly know that the coronaviruses and the measles viruses are completely, utterly different.
Yes.
Types of infection. I think probably in our culture as well, we have ideas of plague. Certainly I was brought up with ideas of plague, 1348, the Black Death, 1666. We have this sort of culture in our background, this underlying fear. And of course, in the medical world, I've been teaching about 1918 pandemic for decades, and I guess we were sort of expecting it to fall into that category.
Yeah, so I think these things are really, really interesting, because they are sort of these they're so frightening and so far away that they are sort of myths of our time. They've become myths of our time, and we can't go back to Black Death and plague and actually pick apart what was really going on. You know, whether people were really well nourished at the time, whether the consequences of people's fear around those things were part of the problem. We don't know. But for 1918, we know a lot, actually, and what we know is a lot different to what we were told. So what we know is that what we're told is contradictory in the first place. So we're told a third of the world caught it, and that the fatality rate was 2 to 3%, and that the number of deaths was absolutely enormous. So the Wellcome Trust currently claim 100 million people died, which is just, I can't remember how many people were alive at the time. I think it was
about 400 million probably.
Right. So, you know, it's a ridiculous claim. Those three numbers don't add up. They don't add up.
There's probably more than that, but you're right, the numbers don't add up.
No, and if you go back to what people were saying at the time, they had pretty good record keeping in 1918. You know, they knew who had died.
Yeah, of course.
And it was modelers in 1920 who were made the assumption that the problems seen in Europe and America could be extrapolated to the whole world. And that based on that assumption, and then also assuming that the whole world will have dealt with it in a much worse way, so they'll have a higher mortality, they came up with a figure of 20 million deaths. So why in 1920 were they, you know, exaggerating the problem and coming up with 20 million deaths? And by this, 2020, they're saying it was 100 million. It's because over the course of the last 100 years, people whose careers depend on there having been something scary in 1918 have inflated that number fivefold. Now, if you go back to the 1920 modelers, we can now say to them, look, nothing happened in China. Nothing happened in Japan. Your assumptions were wrong. It could not have been 20 million. I'm not saying people didn't die, right? They did die. Yeah. But it was not the way the story is told. And one of the interesting, there's several reasons why they might have died more than for a regular flu. And the thing is that the 1918 flu continued to circulate, still around, but it stopped killing people. So why did it kill people then? And obviously there were people who were really, really, really malnourished at the time. There'd just been the war, the soldiers were living in unsanitary conditions, marching, exhausted and vulnerable to infection. There were people who'd been working in munitions factories back home and exposed to all sorts of chemicals, or just living nearby these munitions factories. So that may well have played a role, I don't know. But one story that does seem to have a good evidence base behind it is that there was a huge amount of hope based on the treatment of aspirin. Aspirin was this new drug at the time. They knew it reduced fevers, and they thought that this was the way they were going to get through this. And people were chucking down aspirin in really toxic quantities. There were sort of people describing what was going on with young people who were sick with the fever, but then being given handfuls of aspirin because they were so frightened that they might die. And then if you look at how people died, there were two ways people died. The people have described this very well. There was people who died because they had a viral infection that turned into a secondary bacterial pneumonia. Yeah. There were no antibiotics and they died. There were other people who got sick very quickly, turned blue, had this very characteristic heliotrope cyanosis, they called it, on the lips. They ended up with really edematous, heavy, wet, red lungs at post-mortem. This is not the same condition. That looks much more like aspirin toxicity. So the response to 1918 seems to have been a lot of what happened. It wasn't just what we're told.
It's just so interesting, Claire. I had no idea about that aspirin toxicity affecting the lungs and causing the lungs became inflamed and edematous. They weren't taking in the oxygen, and that caused so basically, how did you describe it? Cyanosis around the mouth, isn't it? The blueness around the mouth.
So they get which obviously you can get cyanosis with pneumonias as well, but this was characteristic. They gave it a name. It was different looking to what they were used to seeing.
I mean, I guess I would call that central cyanosis, which of course is the most alarming form of cyanosis. It means that the oxygen levels in the blood have dropped quite dramatically. That is so interesting. So many things we can learn from the past, and